Afraid, but thank you very much for a generous introduction. And I've known John, Dr. Sinnott, John, for also many years, and he too has had a remarkable career, and you're lucky to have him as well, as I'm sure you all know. So I'm going to talk this evening about glycopeptide resistance in MRSA. I'm going to shift back and forth between some of the research that we have done and are currently doing and more clinically oriented aspects of the subject. If you look at vancomycin resistance in Staph aureus, something that until a decade or so ago we didn't think existed or could exist, we now know that there are at least 4 different types of resistance in MRSA to the glycopeptides. There is true, I'm going to take a chance and see, yeah, the pointer does work. There's true vancomycin resistance, which is due to the acquisition of the VAN8 gene from enterococci. They're the so-called VISA and GISA strains. They're the HeteroVISA strains, which is a terrible misnomer, but that's still in the literature. And then there's this phenomenon of MIC creep. I, until a couple of years ago, kept track of all of the known truly vancomycin-resistant MRSA in the world, most of which, in fact all of which, up until this time came from the United States, and most of which came from the Midwest or from Michigan or Pennsylvania. But I gave up because there are not that many. There are only about 10 now that are really well documented, all from the United States. There are supposedly a couple of strains from Iran, but they have never been substantiated. And there is at least 1 strain from India, which also has not been substantiated. That is, it hadn't been sent to the CDC for the formal testing and so forth. But the point is that these are relatively rare. Most of them have, and by the way, they're not genotypically related. So it's not that a single strain is spread among patients. And virtually all of these have arisen in various types of wounds, either diabetic foot infections or other infections that are colonized and infected with MRSA and VRE. And the VRE have transferred the genes into them. These are not horrible bugs. They haven't spread beyond, there have not been secondary cases. They haven't spread beyond the confines that where they've been found so far. And the organisms are not horribly multi-resistant. All of them that have been tested so far have been susceptible to linezolid and quinupristin dalfopristin, to trimethoprim sulfa, most of them to minocycline, but not all, and all of them to rifampicin. So that's all I'm going to say about them, because they really are not a clinical issue at the present time. They're much more of a laboratory issue. And if you're interested, I can tell you more about the mechanisms and so forth. But if I do that, I won't have time to get through the rest of the talk. And so we'll just leave it at there for the moment. As far as the so-called VISA or GISA, vancomycin or glycopeptide intermediate Staph aureus, these are strains that, the first of which were found by Kenji Hiramatsu in Japan. And Hiramatsu and his group described several strains that had MICs of vancomycin of 8 and 16. And because the criteria for susceptibility to vancomycin at the time said that was an intermediate range of susceptibility, they were called VISA or GISA strains. At that time, resistance by the CLSI and the FDA, which accepted that, was defined as an MIC greater than greater than equal to 32, and intermediate then was 8 to 16. That's now been changed, and I'll talk more about that. It's been lowered, and it probably will get lowered one more time for reasons that I will tell you about as we go along. But this whole thing was the result of the fact that the breakpoints for vancomycin were put together in the 1950s at a time when there was no vancomycin resistance, and it was basically put together on the back of an envelope, just like people approved vancomycin. Vancomycin was approved by the FDA with a skeleton set of data over about a 3 or 4 day period, because they had nothing to treat MRSA at that time. Shortly thereafter, we got nafcillin and the anti-staphylococcal beta-lactamase, penicillin. Never mind. The beta-lactams that work against penicillin-resistant MRSA, Staph aureus. But what happened was that the organization that set the breakpoints at that time, the CLSI, said, well, what are we going to do? We don't have any resistance. So we know what the peak and trough serum levels of vancomycin are. We know that trough levels with standard doses are around 10. So if an organism has an MIC of 8 or less, it ought to be susceptible. So they said, okay, that's susceptible. We know that peak levels can be very high, but they average around 30 or 40. So if the MIC is 32 or greater, that's probably resistant, and everything else in between is intermediate. That's how they were set, and they stayed that way for 30, 40 years until these organisms came on the scene. When we first started studying these, and when Hiramatsu first started studying these strains a little over 10 years ago, we thought, because we obtained his strains and a number of strains from around the country, that they might be clonally related. We now know that that's not true, but the first strains from Japan and from the United States were very closely related and probably were clonally related. They all belong to AGR group 2, and I'm going to tell you more about that in just a minute. They didn't contain any of the VAN A, B, C, D, E, or G genes. They had abnormalities in penicillin binding production, but that has not turned out to be very important in terms of resistance. But what is important is the fact that they produce a thickened cell wall that's not normally cross-linked. And as a result, there are a large number of peptides that are not cross-linked and instead end in D-ala-ala, which is the target for vancomycin. So it acts like a sponge, it binds vancomycin, and that's why they have this mechanism of resistance. And this is just an electron micrograph of some of these sort of thick, fuzzy cell walls, which you can see here. They also show decreased autolysis when exposed to vancomycin. Now, we began thinking when we started looking at these that perhaps, because some of the functions such as autolysis and some of the other functions that we knew were abnormal in these VISA strains were under the control of an operon in staph called AGR. It stands for accessory gene regulator. It's an operon that is one of the master operons of staph. Staph has at least 4 or 5 operons like this that control many of the functions of the cell, but this is one of the most important ones, and it controls the expression of and the production of the quorum-sensing octopeptide that's also known as an auto-inducing peptide. And when we were talking this at noon, we talked a little bit about that. This is a peptide by which staph can communicate with one another, know when they've reached a critical mass to cause infection and so forth. But it also is a peptide that's very important in virulence and so forth. It controls the expression of cell surface proteins that enable the organism to bind to mammalian cells. It controls the expression of exotoxins, a whole series of exotoxins, all of the exotoxins, in fact, produced by staph, including the Panton, Valentine, leukocidin. And what happens is Staph aureus reaches stationary phase as it goes through the growth phase. The AGR system represses the genes encoding for cell surface proteins and activates the expression of these toxins. And if you look at the operon, it looks in cartoon form something like this. 4 major genes, AGRA, B, C, and D. B encodes the probable, because this has never been absolutely proven, transmembrane protein that serves as a channel for G, which is the octopeptide, so it can get out of the cell. The auto-inducing peptide then binds to the gene product of AGRC, which is a specific receptor. And this is how the organisms are classed as AGR 1, 2, 3, or 4. There are 4 different types of the AGRC receptors and 4 different types of peptides which bind to them. And one will bind to 1, 2 to 2, but not vice versa. And that's another way in which they communicate. Once the auto-inducing peptide binds to AGRC, it causes autophosphorylation, in turn transfers that phosphate group to AGRA. So phosphorylated AGRA now interacts with the promoter, several promoters, P1, P2, and P3, that drive the system in circular fashion this way, but also produce RNA3, which turns on virulence factors. And if you alter this system, then what happens is you can alter it in such a way that it alters the ability to lyse the cells, autolysis, or it alters the production of virulence factors. This just shows you that there are these specific AGR 1, 2, 3, and 4 peptides. I'm not going to spend time with that. Well, what we found, which was very interesting, is when we began looking at the GISA and VISA strains, that they appeared not to be producing a number of the toxins. We were particularly looking at the delta lysine, but a number of other toxins weren't being produced. And so we went back and we sequenced the operons in the strains, and what we found was that they had mutations, that there were mutations in all of the strains that we looked at that time. Some in AGRB, some in AGRC, some in A, none in D, which encodes that octopeptide. We didn't find any mutations upstream or downstream, although subsequently those have been found too. That is, in some of the promoters and so forth. There are also in the control genes potential mutations. But what this means is that the AGR system in these strains is shut down. So it's shut down at a point where the cells make large amounts of biofilm, where vancomycin inhibits but doesn't kill them, so because autolysis is turned off, and they don't make virulence factors. And we'll come back to what that all means in a minute. But that plays a significant but not total role in these VISA strains. Now, confirmation of that came from this study, subsequent study by Alex Tomas and his group at the Rockefeller, who did a whole genome sequencing of a strain that developed resistance during therapy in a patient with a congenital heart disease, Johns Hopkins, who had a MRSA infection, was treated for months and months and months with vancomycin, and in the course of that developed a significant vancomycin resistance strains became VISA strains. And what they found was very interesting. They found that the MICs went from 1 to 8, not surprising. There were only 35-point mutations involved in this, and most of those probably didn't have anything to do with the resistance. The most important operations they found, again, were in the AGR operon, AGRC, just as we had found earlier in that. So it confirms that. And in the operon that contains the VRA gene, which is part of a 2-component regulatory system I'm going to talk more about, but it has something to do with cell wall synthesis. The other thing that they found, which is interesting and has now been repeated over and over and over again, is that this strain, which never saw daptomycin, developed resistance to, or not resistance, but the MIC went from 0.01 to 1 to daptomycin. So exposure to vancomycin led to increases in dapto-MICs. Subsequently, the Hiramatsu group again began looking at this, and they found once again that there were 2 types of mutations involved here. One is a mutation that involves VRSA and the other GRAR, and it turns out both of these genes are involved in cell wall synthesis. And to make a long story short, basically what they found were mutations in the regulatory genes for these that led to overproduction of the gene products. And when that happens, they produce more cell wall. And that's exactly why they have the thickened cell wall and so forth. And it takes 2 of these mutations to make VISA strains. If you only have 1, you have a HeteroVISA strain in that setting. Now, that gets us to the HeteroVISA. Now, what are HeteroVISA? This is a, you can't read this, and don't try to read this. This is a case report that we wrote about it purposely so you can't read it. This is from about a patient that I got called about a number of years ago from Washington University in St. Louis. Gary Weil, who's a good friend of mine, who's an ID person at WashU, called me and said, Bob, he said, you know, I need some help. I don't know what to do with this patient. I said, yeah, what's going on? He said, it's an 80-year-old man who underwent aortic valve replacement, and postoperatively he has high-grade Staph aureus MRSA bacteremia. I've had him on vancomycin now for 3 weeks, and he has consistently positive blood cultures for 3 weeks. I said, is it the bug resistant to vancomycin? No, the MIC is 2, which is susceptible. Are your blood levels of vancomycin adequate? Yeah, the troughs have never been lower than 10. I said, well, you know what to do, Gary, as well as I do. I said, you got to take the valve out. He said, Bob, if that's the answer I wanted, I wouldn't have called you. I know that. He said, but the surgeons won't touch him as long as he's bacteremic. And I said, well, as long as surgeons won't touch him, he will be bacteremic. And so what do you do? And so out of desperation, I said, why don't you give him some linezolid and see what happens? And he called me back in 3 days, and he said, you won't believe this, but for the first time in over 3 weeks, we have negative blood cultures for 48 hours on this guy. And sure enough, his blood was sterilized on linezolid. He went to surgery. This is not an advertisement for linezolid and endocarditis, because the valve cultures were still positive when he got to surgery, but it cleared the bloodstream infection, and cleared it very, very quickly and very, very effectively, and allowed him to go to surgery. About the same time, Chip Chambers published this paper in AAC. This is a drug addict in San Francisco who developed right-sided endocarditis due to a MRSA strain. The initial strain had a vancomycin MIC of 1 and didn't show this phenomenon of heteroresistance. And when he put this into his rabbit model, you could see that the titers in the vegetations went down 7 logs, so it was very, very effective. But this guy relapsed, and when he came back with the same strain, now the MIC was 2. Now it showed what we're going to talk about in a minute, heteroresistance, and now vancomycin was totally ineffective against it, even though the MIC was only 2. So what is heteroresistance? These are strains that routinely test as susceptible. MICs now of, this is an old categorization because it's now 2 or less, but containing subpopulations with reduced susceptibility, MICs greater than or equal to 16 micrograms per ml. The concentration of the subpopulations is less than 10 to the 4th, and so they escape detection in the clinical microbiology laboratory because you can't see and you don't look for colony counts that low. Often these strains, just like the VISA strains, have abnormalities in AGR function, show decreased virulence, tolerance to glycopeptides, and increased biofilm production. And there's a very high clinical failure rate when they're treated with glycopeptides. The problem with heteroresistance is it's very tough to measure it in the laboratory because you have to do extensive testing. You can do quantitative serial MICs, that is, you do MICs in which you do tube dilutions in which you do essentially 1 microgram, 2 micrograms, 3, 4, 5, 6, 7, all the way out to 16, and then you subculture these and look for just a few colonies and see what goes out. That's one way to do it. You can do the modified population analysis profile which is Mandy Wooten's test, in which you determine an area under the curve from these quantitative MICs and compare it with the area under the curve for a control, which is a known VISA strain, and then you get the ratio, and then that'll give you the answer. Those are the two gold standards, and both of them are beyond the realm of most routine clinical labs. You can do a modified E-test in which you use an increased inoculum, twice the inoculum you standardly use, and I'll show you that. And that's not a bad screen for this. It's better than, or you can probably screen for delta lysine production, which is a surrogate, because most of these have the AGR abnormalities and they don't make delta lysine, and that's a pretty easy thing to do. Here's that modified E-test, and this is a heteroresistant strain. You can see it looks like the MIC is 2, but you have growth all the way up to 16 of these small colonies here, and this is heteroresistance. Well, what does it mean? Ben Howden in Australia, in Melbourne, reviewed 25 cases of patients infected with heteroVISA. Serious infections, as you can see here. 3/4 of them failed glycopeptide therapy. That is, they had positive blood cultures for more than 7 days. But the interesting thing is that ultimately 80% of them were cured with alternative therapy. So they didn't die, but they had to receive alternative therapy. This is a more recent study during the past year in the JID, in which Maurer and colleagues did a retrospective study of 27 heteroVISA cases, which they compared with 233 standard MRSA bacteremic patients. They found the duration of bacteremia was greater with the heteroVISA patients, 12 versus 2 days, more endocarditis, more osteomyelitis in the heteroVISA patients, and more emergence of rifampin resistance. But what's also interesting, again, this will come back time and time again, no difference in infection-related mortality. So should the labs now be testing routinely for heteroVISA if you have serious Staph aureus infections? In this study, which is, I have some problems with this study, but it's not a bad study. This is from Melbourne, again, and Denhausen and his group. Prospectively studied patients there to correlate clinical status, colonization versus therapeutic outcome with detailed susceptibility testing. They had 58 patients with reduced vancomycin susceptibility in their MRSA, and 59 were susceptible. And basically they found out that there was a lower infection rate once they were colonized with the reduced susceptibility strains, and a lower rate of bacteremia with those strains. The cure rates were not different. They said this is a mistake. It's 0.43, not 0.043. Although there does appear to be a numerical, if not statistical, difference there. They concluded that you shouldn't do routine testing for heteroresistance, but you should reserve it for patients who don't seem to be doing well or who have persistent bacteremia on vancomycin or glycopeptides, and that's the group which you should do the testing. The CLSI recently, and when I say recently, it shows how time flies because it was exactly 4 years ago that the CLSI dropped the breakpoints for vancomycin, so that now 4 or less is susceptible. I'm sorry, 2 or less is susceptible. 4 and 8 are intermediate. I'll show you in a minute. And in support of that, Fred Tenover and I pulled out 16 cases from the literature and from our own experience of patients who had bacteremias with strains that had MICs of 4. And this is half of them here. And what was striking about these is the duration of positive blood cultures on vancomycin. 29 days, 8 days, 13, 12, 33, 8, greater than 7, greater than 13, 12, 39, 42 days, 22, 35, 42 days. These are failures by anybody's definition, failures of vancomycin therapy. You wonder why the clinicians left them on vancomycin so long with positive blood counts. Because they didn't have an alternative and they didn't know what else to do. That's really what happened. But the other thing about this, pardon? Yes, this was before daptomycin, and this was before. Well, linezolid was probably out, but people didn't think they should use it. I'm sorry. Well, I can't answer for most of these patients. A couple of them actually came from our own hospital, and in those cases, they were either resistant to rifampin. Some of them were resistant to rifampin, and there just wasn't any alternative. I know that's, but the other side of the coin, because I've seen a couple of these patients myself, is that these patients looked well. They didn't look sick. And so they seemed to be fine. Sometimes they were afebrile, and they just had positive blood cultures going on and on and on. Anyway, that led to the changing of the breakpoints, as you see here, as we just said. And that gets to the final type of resistance, and that's this MIC creep. Before we look at that, this study by Ree et al. Also shows another phenomenon, and that is that it appears that the percentage of tolerant isolates has gone up with time, the vancomycin tolerance. In fact, I think this is a conservative estimate in this study. But the group from MD Anderson really sort of put MIC creep on the map with this study, which has never been published except at ICAC. But they looked at the MIC 90s of staff and MSSA between 85 and 2004, and the MIC 90 went up to from 0.12 to 2, a very significant increase, as you can see. And MRSA, same thing. So this is MIC creep. A lot of other groups have shown it. This is from a study from Toronto. No, from Golan. This is from New England Medical Center. You can see from 2002, the median MIC has gone from 1 up to 2 here. This is a study from another study from AAC showing the same phenomenon. Same thing here with Wang. Now, there are many examples of this in the literature, but not everyone has seen this. And Ron Jones, who's done a huge survey of the United States, has not been able to demonstrate this phenomenon in a series of US-wide isolates. And I think that what the story here is that it's institution and area specific. Some areas see it and some don't. And when you put everything together, it washes it out, as was the case with Jones. Now, the potential clinical significance of this was first shown by George Sakoulas, who was working in our lab at the time, and he took a series of patients who had received either quinupristin, dalfopristin, or linezolid in compassionate use trials because they had either failed or were intolerant of vancomycin. And so this study is clearly enriched for vancomycin failures. And so that's why these numbers are as low as they are. Fortunately, you can't read them here, but that's probably a good thing. But what he found was that the cure rates were almost 60% for vancomycin if the MIC was less than or equal to 0.5. But if it was 1 to 2, the cure rate went down to less than 10%. And others now have shown the same thing. This is a study from Hidyat, subsequently published low MIC strains versus high MIC. And they use 2 as the cutoff point, 85 versus 62% response rate. Here's another study by Tom Lodis and his colleagues, and the difference, high MIC, low MIC, they used 1.5 milligrams per liter, micrograms per ml as the cutoff, and again, a significant difference in this setting. How frequent is heteroresistance? Well, we don't know. This study this is the most this is the highest frequency of any place in the world that I've ever seen. And this is a study from Jan Bell in Perth, Australia. And she looked at all of her isolates and found two things. That as the MIC goes up from 1 to 4, the percentage of heteroresistance in her strains went from almost 60 to 100%. Same thing was true for teicoplanin. Nobody else in the world has shown numbers quite that high. And the best I can guess is that in the United States as a whole, and this is totally a guess, it's about 20% right now among MRSA. But we need somebody to do a big study, but it's a pain in the neck to do these studies. And up to now, no one has done it in the US. Now, the other thing that's really interesting, and I alluded to this 3 or 4 times, so you're tired of hearing this, and I'm about to show you why this is the case. It is shown again in this recent study by Soriano et al., who looked at outcomes based on MICs 1, 1.5, and 2. And what he found was there was no difference in mortality, no difference in infection-related mortality, and shock was actually much less frequent in the more resistant strains than in the others. So again, that's a hint. These are less virulent. So obviously, the obvious thing to do is ask the question, are they less virulent? So we did that. And we used 2 models. We used the C. elegans model, which is a worm model, and we used the Galeria melanella model, which is a caterpillar model. And both of these models really correlate very well with what happens in mammalian systems and in humans. And in both of them, we were able to show that these heteroresistant strains, including VISA, show markedly attenuated virulence. And Kennedy and colleagues in a paper published about the same time did the same thing in mice and showed exactly the same thing. So these strains are less virulent. And this is these are some of the data from a paper that was published just about a year ago in JID from our group that shows this. And basically, one question is, well, maybe they're less virulent because they grow more slowly or because they are somehow not fit. And so we looked at that, and you can see all of these strains that we studied grew the same. This is a control for decreased fitness here, and so it wasn't an issue of growth rate. But one of the things that we saw again in these strains was they all had decreased or absent AGR function. Some of them to begin with, and all of them at the end. And if we knocked out the AGR genes in this system, again, you markedly decreased the virulence of these strains. So they are less virulent. And that's where the story sits right now. That's not to say these aren't to worry about, because bacteremia is a bad thing, and they'll ultimately seed other places and things will go on, but they don't kill patients, and they give you time to look for alternative therapy in these patients. The other question is it possible to overcome glycopeptide resistance by increasing the dose or other innovations in vancomycin administration? And you may or may not have seen there are 3 papers now. This has been published 3 places, so I get really in trouble for duplicate publication, but it was done on purpose because it was by 3 different agencies that wanted us to do this, set up these guidelines. These guidelines took about 5 or 6 years to put together because it was very hard to get a consensus here, but we managed to do it. And here are the major findings, and I'm not going to go through all of these findings right now. And in fact, what I'm going to do, instead of going to, if you want, you can look at the reference, the summary of this, which is in Clinical Infectious Diseases last August. But what I'm going to do is pick out various aspects of this and show you the data behind it. So in terms of sort of newer approaches to glycopeptide therapy, they include using a loading dose, giving it by continuous infusion, and then the most important thing, the use of trough levels as surrogates, adjusting the dose based on the MIC, and then the question of the use of supratherapeutic doses. And we'll look at all of those. The guidelines recommend a loading dose for serious infections with absolute admission that there is no evidence of increased clinical efficacy if you do that. It's purely a pharmacological, pharmacodynamic recommendation. And I, despite my name being on those guidelines, don't do it. But you can do it or not do it. I mean, it's a perfectly reasonable thing to do, but it's also a perfectly reasonable thing not to do. What about continuous infusion? There's a lot of stuff in the European literature about continuous infusion of vancomycin suggesting that it's more effective. But the half-life of vancomycin is 6 to 8 hours. And you give it every 12 hours. And the trough levels, if you give it appropriately, never go below 10. And therefore, you are, in essence, giving it by continuous infusion when you give it every 12 hours. And so there is no evidence, again, of clinical efficacy. And if you do what they suggest in Europe and you maintain a steady state trough level of 20, in order to do that, you will likely give a toxic dose of vancomycin. So we don't recommend that at all. This is the most important slide of the entire talk. And this comes out of these recommendations. And this is relates to the use of trough levels as surrogates for the AUC and adjusting the dose of vancomycin based on the MIC of vancomycin for the infecting organism. There are 2 studies now in animals, one by Bill Craig's group and one by Jerry Shentag's group, both of which show that success for in this case it's their skin infections in neutropenic mice is related to having an AUIC, an AUC to MIC ratio of greater than or equal to 400. That's okay, but it's not a human study. But Shentag and his colleagues have recently also published a study, which is down here, most broader, that looked at it in humans and showed exactly the same thing in Staph aureus pneumonia. So I think that's a real number, and I think that the data on which this is based is valid, are valid. So we now also know that trough vancomycin levels correlate with the AUC, and therefore you can use them as a surrogate. Nobody can measure enough levels to get an AUC in order to dose vancomycin. But fortunately, the trough levels correlate very nicely with AUC. And here's how it works. A standard 2 gram per 24-hour dose in a patient with a 70 kilogram patient with normal renal function yields trough levels of 5 to 10 micrograms per ml, milligrams per liter. And that gives you an AUIC of greater than 400 for organisms having a vancomycin MIC of equal to or less than 0.5 micrograms per ml. And that's the majority of MRSA still in the United States at the present time. In order to get an AUC-MIC ratio of 400 for organisms with an MIC of 1, you need a trough of 20, and you need a 4 gram per day dose. To obtain an AUC-MIC of 400 for organisms with an MIC of 2, you need trough levels of 40 and an 8 gram per day dose in order to do it. Now, what happens when you give those big doses? Well, one question is toxicity, and the second is efficacy against resistant organisms. And I can deal with the second very quickly. There is no evidence that these high doses give you better efficacy. What about toxicity? Well, this is a study that George Sekoulis did again and just published in AAC, which basically re-raised the question of ototoxicity with vancomycin in elderly patients. It's not a definitive study, and I just throw it out there to say that we thought for the last 20 years that vancomycin was not ototoxic, the modern preparations. This study suggests that it could be, and I throw it out there saying, for whatever it's worth. It's not enough that I'm going to change my use of vancomycin based on it, but I'm going to watch the literature for further studies. What about, I'm sorry?
Many of the autologous view vancomycin as ototoxic.
Yeah, I know. And the reason they do, John, is because there's a lot of stuff in the older literature about vancomycin toxicity. This is the literature from the 1950s when it was first used. A lot of it comes out of studies that were done at Mayo Clinic at the time, where they overdosed the dog. They got serum levels in the hundreds, and patients got tinnitus and other things with it, and they felt it was ototoxic. However, subsequent to that, in the 70s and 80s, they did huge numbers of animal studies with vancomycin, and they could never show in any of the animal models of ototoxicity, any evidence of ototoxicity. And then when they reviewed the clinical data of the modern, more pure preparations, no evidence that they could find. This is the first study now that comes back or the previous slide, to that possibility again. But the otologists know the old data, and if you read the old Goodman and Gilman or things like that, it says it's nephrotoxic. I mean, it's ototoxic. The issue of nephrotoxicity comes up here, and that's a different story. There are lots of studies of nephrotoxicity, including an old one that we did many years ago, that suggests that vancomycin isn't particularly nephrotoxic unless you give it with aminoglycosides or other nephrotoxic drugs, in which case 40% of the patients will develop nephrotoxicity. It's a striking synergistic toxicity. But there are several other recent studies that suggest that high dose of vancomycin therapy may bear a cost of nephrotoxicity, but they were inconclusive. But two recent papers by Lodis and colleagues, which is George Giussano's group, show that vancomycin doses of greater than or equal to 4 grams a day are definitely nephrotoxic, and that nephrotoxicity is correlated with serum levels. This is the first, published a little over a year ago in AAC. In which they did a cohort study of nephrotoxicity in patients at Albany Medical Center, and they compared patients on linezolid with patients getting less than and patients getting greater than equal to 4 grams per day of vancomycin. And you can see the difference in nephrotoxicity, clearly statistically significant, even though the numbers are relatively small. They then went back and redid the data and came up with this fairly useful nomogram, which you can see here, which correlates probability of nephrotoxicity with the trough levels of vancomycin. And they compared ICU patients and non-ICU patients. ICU patients are more likely to develop it than not. And they use and the cutoff here of 20 is where they felt the inflection point should be, even though these are fairly continuous curves. And that means that with a trough level of 20, you'll see nephrotoxicity in 40% of the patients in the ICU and in about 20% of the patients who are non-ICU patients. And that's the basis now for the recommendation not to increase trough levels greater than 20 or 25. They also had a wonderful poster at ICAC, and I hope they will publish it very soon, in which they took all of the stuff that I've just told you and put it together in a single little sort of card form that you can carry with you if you want it in terms of dosing vancomycin, and that should be out very soon, but it's not yet. So what are the final recommendations you can take? Well, certainly for the current glycopeptides, for vancomycin-resistant MRSA, and by the way, I'm not including the telavancin here. This is vancomycin and teicoplanin. It obviously won't work for vancomycin-resistant MRSA. It won't work for VISA or GISA. By definition, these are patients that have failed glycopeptide therapy. If HeteroVISA, for HeteroVISA, we don't know for absolute certain, but most of these are identified clinically by failure to respond. And so you have to say that certainly for bloodstream infections, endocarditis, meningitis, pneumonia, don't use it. It won't work. For less severe infections, skin and skin structure infections and so forth, it probably will work against these strains, but we don't know that for sure. That's just my guess. And if you have elevated MICs, then base the dose on the MIC and use that information that I gave you in that previous slide. And again, less severe infections may respond to lower doses. We just don't know. Now, this is a very interesting study that was just published a couple of months ago from Korea, in which it's not a perfect study, but it's one of those studies that makes you think and makes you look and ask what's going on and say, hey, I think I saw similar things myself, and there are similar things in the literature. Basically, what they did was they took 35 patients who had persistent VRSA bacteremia on vancomycin. That was the start. I've forgotten exactly what their cutoff. It was greater than 7 days. I think it was even more than that. And then they looked to see what happened if you just continued the vancomycin with it either alone or with the addition of aminoglycosides or rifampin, or if you stopped it and switched to linezolid. And what happened was really rather striking. In the vancomycin continue group, the 30 mortality rate was 53%. In fact, the numbers are small, unfortunately, but it went up to 80% if you added either aminoglycosides or rifampin. Didn't seem to work. Wish the numbers were bigger, but it's interesting. But look what happened with linezolid. Here, with linezolid alone, there was no mortality, and if you added a carbapenem, the mortality was 22%, and it looked like linezolid was effective in that setting. Now, why should it be effective? And we've already said it's a static drug, bacteremia, and I gave you an example of a couple of patients from our own experience where we saw the same thing. Well, one explanation may be from Hiramatsu's group again. He always has a different first author, but this is Hiramatsu still from Japan. And what they found, and we've confirmed this, we've shown the same thing. There's a negative correlation between vanco and linezolid MICs in VISA strains, and probably HeteroVISA strains. Whether they're direct clinical isolates or whether they've been made in the laboratories. So as the vanco MIC goes up, the linezolid MIC goes down. They become more susceptible to linezolid. Why that is, I have no clue, because it doesn't change the MIC to any of the other antibiotics, chloramphenicol, clindamycin, azithromycin, quinupristin, dalfopristin, that work on the ribosome at a similar point. So there's got to be some, if this is true, there has to be some other mechanism for it. I throw this out again as an interesting observation. I don't throw this out as dogma, because it isn't a dogma at this point. But I can tell you we've confirmed this observation of the inverse relationship among some of our strains as well. Now, what the clinical significance of it is, I don't know, and whether it even accounts for the results by the Korean group or not, I don't know, because the numbers in the Korean study are really small. So what are the therapeutic options then? Well, we know that vanco and tyco aren't going to work for VISA and GISA strains. Agents that may work if the organisms are not heteroresistant include dalbavancin, ridavancin, telavancin, and daptomycin. And I don't know how our time is here. I have a sneaking suspicion that I'm going way over, in which case, pardon? All right, because I'll talk a little bit about that then. I want to talk about that for a few minutes. The agents that are likely to be effective if it's susceptible in vitro, and this is not necessarily for bloodstream infections. These are just in general, the ones that people are currently using for skin and skin structure infections. Rifampin is a big asterisk, and we talked a little bit about that at noon, and I can come back to that. And then the other agents that probably have effectiveness include linezolid, quinupristin, dalfopristin, tigacycline, ceftobiprole, ceftaroline, and nicloprim, which is probably dead. Now, this is daptomycin. And the concern that I have about daptomycin in bacteremia is this data that I've, and again I mentioned that at noon, that I've extrapolated. It's not published in the article, in the New England Journal article, but if you pull out the MRSA patients in general and look at the emergence of resistance, it was 11%. 5 out of 45 developed resistance during therapy. And that's an issue for serious infections with daptomycin. Now, okay, something happened to this slide in terms of the formatting, but that's all right. We don't need it.
what this did show in graphic form, I don't know how it came out this way. I've never seen it like this before. There's some studies that, again, we're done in our laboratory that look to see what happened to daptomycin MICs and to heteroresistance when you took patients, either patients who had developed heteroresistance on vancomycin or did it in the laboratory, and basically we were able to show cross resistance to daptomycin in those strains. And not only did we show that, but about the same time, this is just through 2006, there were 1, 2, 3, 4, 5, 6, 7 different groups that confirmed the same thing. So it's a real phenomenon. What does that mean in terms of daptomycin and VISA strains? It tells me that if you're going to use it in that setting, you got to really be on the lookout for the development of resistance. It also tells me that if you're going to use daptomycin, it's probably better to use it as initial therapy rather than salvage therapy for vancomycin failures, because the vancomycin failures are set up to develop daptomycin resistance in that setting. Now, there's probably more to this story to be written, and we and others are looking at ways to prevent daptomycin resistance, particularly with various antibiotic combinations. And I think it may be possible to do that. But it is an important issue, and it's something that does need to be looked at when using that drug. Telavancin is shown here, and telavancin is basically a semi-synthetic derivative of vancomycin. If you take this lipid side chain off and you take this phosphate complex off, you have vancomycin. So that's what it is. It's a lipid form of vancomycin, but because it has this lipid tail, it acts more in some ways like teicoplanin and like the teicoplanin drugs than it does like vancomycin, which means that it does not work very well against VAN-A, vancomycin-resistant enterococci. It's a which I've just already said here. It has a unique mechanism of action, that is a dual mechanism. It inhibits peptidoglycan or cell wall synthesis and perturbs cell membrane function. And theoretically, that should make it less likely for bugs to develop resistance, but we don't know that for sure. Good activity against gram-positive organisms. I list plus or minus vancomycin resistant. I think that really should be minus vancomycin resistant MRSA. And the reason I have the plus minus I'll show you in a minute, because there's some data that show the MICs go down a bit, but they don't ever go into the susceptible range. So it has some activity, but not enough to be useful. It's rapidly cidal. It was approved last October for complicated skin and soft tissue infections due to a variety of gram-positive organisms, which you can see here. The dose is 10 milligrams per kilogram per day by a 60-minute IV infusion. It's given by 60-minute infusion, just like vancomycin, to prevent the so-called red man syndrome, which it will cause. There's a warning for pregnant women because it has caused fetal abnormalities in animals. And so there's a big black box warning about that. It should not be used in pregnant women. It does have a little bit more nephrotoxicity than vancomycin, 3% in the clinical trials versus 1% for vancomycin, but it's certainly within the realm of handling it. The major side effect of the drug is that it causes a taste dysgeusia, a bad taste, and some nausea and vomiting in 10% or less of the patients who get it. Sounds a little bit like tigecycline, but in that setting. These are the results of the Atlas trials, the pooled data, and this was an interesting complicated skin and skin structure study. I won't go into great details, except if you look at the overall therapeutic response in MRSA, you can see that it was more effective numerically than vancomycin, and it just missed by probably 2 cases being superior to vancomycin in that setting. And you're going to see that again in another study, which I'm going to show you in just a moment. And that is in the HAP and VAP studies. And this stuff is not published yet. These are data that David Freeland gave me from Theravance, but subsequently an abstract with these data in it, it was presented at ECCMID. But again, if you look at the most difficult patients, the VAP patients, and clinically evaluable patients, telavancin cure rate was 80% versus 68% for vancomycin. Sounds very much like linezolid, doesn't it, in that setting in these HAP and VAP patients. And so there's no question in this study, in the microbiologically valuable patients, which is an important group, the cure rates were 82 versus 74%. Again, not statistically significant because of the numbers, but again, it's all consistent. So the drug does look like it works for MRSA, and it may be better than vancomycin. Now, the real question in my mind, and this is what I'll end on, is whether or not these new drugs, and that includes dalbavancin and aureus, work against HeteroVISA and VISA strains. And because that's the key question. If you're really going to use them in place of vancomycin, they need to work against those strains. Otherwise, you don't have very much of an advantage. The problem is you can't get the data out of the literature. And the reason you can't get the data, I'll show you what's in there, and that's what's on here. These are data that I've summarized from the literature all over for the activity of vanco, dapto, dalbavancin, aureus, and telavancin. These two drugs, by the way, are still in development, believe it or not. Dalbavancin has been picked up by a new company. Pfizer got rid of it and gave it to a company that has a name that I will remember in a minute because I remembered it earlier today. It's Duranta. Duranta is the name of the company. It's a new company that has it. And aureus has been picked up by the Medicines company. But they're at least 2 or 3 years away if we're optimistic from the marketplace. So you're not going to see them for 2 or 3 years. And they may still die. But anyway, I've included the data because they're still alive. So what you see here is that obviously that for MRSA, all of these drugs work pretty well. For vancomycin-resistant MRSA, daptomycin is very effective, as you'd expect. Dalbavancin, not very effective. In fact, I don't know where this 0.5 came from because dalbavancin is a teichoplanin derivative, and therefore it's not going to work against the VAN-A. So I'll accept this number, but not this number from the studies in the literature. Aureus works, and it should work. And here's telavancin. You see it's 2 to 8. It's not way high, but it's down there, but not good enough, I think, to be useful in that setting. Then you get down to the VISA-GISA. And here you see that daptomycin looks like it's effective, but a recent study from the CDC by Jean Patel showed that 93% of the VISA-GISA that she studied had daptomycin MICs greater than 2. And that's consistent with what we talked about before. That is vancomycin resistance correlating with daptomycin resistance in that setting. The others all seem to work. If you test aureus with tween, the MIC goes down, and that's probably appropriate in telavancin. But in none of these studies did they look for heteroresistance. These are just MICs. And so without knowing that, you can't answer the question. And if you look at heteroresistant strains, same thing is true. They look like they all work, but nobody tested and did the population analysis study. So we really don't know. So what do we do? Well, the only thing we can come at is we have no human data. Is to look at a couple of animal models. And this animal model, which was done by Theravance, neutropenic mouse bacteremia, telavancin, they said, worked against GISA and HeteroVISA, which failed to respond to vancomycin in that model. But there's not much. There is some data on it, and it's in this paper here published in 2009. So in that model, it looked like it worked against it. In the rabbit endocarditis model, telavancin was more effective than vancomycin against 2 GISA strains. And here are the data from that. And you can see that, again, these are 2 GISA strains. And just look at the vegetation titers after therapy. I think this was a 3-day, it may have been a 5-day treatment group. You can see that vancomycin had some effect, telavancin a bit more effect, and this was the only statistically significant advantage. There was no advantage in terms of sterile vegetations, and there was no statistically significant difference in the other strains. So I don't know what to make of it. I think the ball game is still wide open here, and I think we don't know exactly whether it will work. So that leaves me then with this assessment of telavancin at the moment for glycopeptide-resistant MRSA. Certainly don't use it for MRSA. It may work for GISA and VISA. It probably works for HeteroVISA and VISA, and it will work for Vancocreep because it's intrinsically more active than vancomycin in that setting. So, what do we have to do for GISA and HeteroVISA? We need further studies of the clinical efficacy of the newer agents, especially the new glycopeptide derivatives and daptomycin, and the remarkable ability of Staph aureus to acquire new resistance mechanisms is a real challenge for all of us. And that's all I have. Yeah.